Is the most widely used system to describe the anatomical relationship between an anal fistula and the anal sphincter complex. For your PG exams, this is the gold standard for determining the risk of postoperative fecal incontinence. The classification is based on the internal opening and how the fistula tract traverses the internal and external sphincters. The four main types. Parkes classification. Type: path of the tract. Prevalence. Clinical significance. Intersphincteric. Stays between the internal and external sphincters. Does not cross the external sphincter. Most common, 70%. Lowest risk of incontinence after surgery, fistulotomy. Transsphincteric. Crosses both the internal and external sphincters into the ischiorectal fossa. 25%. High versus low. Crossing more than 30% of the sphincter increases surgery risk. Suprasphincteric. Loops over the top of the puborectalis muscle and then descends. Rare, 5%. High risk, requires a Seton or complex repair. Extrasphincteric. High tract starting from the rectum above the dentate line, passing through the levator ani and exiting the skin. Very rare, 1%, usually due to trauma, Crohn's or pelvic malignancy. 1. Intersphincteric, the most common. Path. Starts at the dentate line, right arrow crosses the internal sphincter, right arrow travels down the intersphincteric space, right arrow opens near the anal verge. Example. Because it doesn't involve the external sphincter, the main muscle for continence, a simple fistulotomy, laying open the tract, is usually safe. 2. Transsphincteric. Path. It bores through both sphincters like a tunnel. High versus low. If the tract crosses the sphincter at a low level, it can be laid open. If it is high transsphincteric, cutting it would cause incontinence. 3. Suprasphincteric. Path. It travels upward in the intersphincteric plane, goes over the puborectalis, and then heads down through the ischiorectal fossa to the skin. Key detail: it involves the entire external sphincter and the puborectalis. Never perform a primary fistulotomy here. 4. Extrasphincteric. Path. This is the only one that doesn't necessarily start at the crypts. It bypasses the entire sphincter mechanism. Association: often associated with high-level pelvic inflammation or iatrogenic injury, e.g., a high-pressure probe during a previous surgery. Associated rule: Goodsall's rule. You cannot discuss Parkes without Goodsall's rule, which predicts the path of the tract based on the location of the external opening. Posterior openings follow a curved tract to the midline at 6 o'clock. Anterior openings follow a straight radial tract to the nearest crypt. Exception: an anterior opening 3 cm from the anus may follow a curved tract to the posterior midline, acting like a posterior fistula. High yield examples: investigation of choice, MRI pelvis.